Welcome to the next installment of Live Well with UCI Health. My name is Gina Grad. I'm from 98.7 and iHeart Radio. And I'd like to introduce Dr. Tsai. It is so great to have you here. Thank you so much. Let me do a little bragging about you. And if I leave anything out, please fill us in. Board certified breast radiologist and director of breast imaging at UCI Health. Does that sound about right?
Sounds right.
Okay, wonderful. Also an associate professor at the UC Irvine School of Medicine and chief of breast imaging for the Department of Radiological Sciences. Ooh, I'm tired just from saying that. That's amazing. Thank you.
Thank you for having me.
Of course. So many important questions and such an important topic for half the population. But I have to ask you a personal question right off the bat. What is dense breast tissue and why am I always asked if I have it? Whenever I go in for a mammogram, it's the first thing I'm asked. I'm like, I don't know. Is that a normal question?
Thank you for that question. And we get this question all the time.
Okay, good.
All the
So
time.
it's not
Every
just
day.
me.
I get it every day.
Okay. Tell me,
Yes.
how would we know if we have it and what do we say?
Yes. So listen, every woman's breast tissue is made up of this fibroglandular fibrous tissue and fatty tissue.
Right.
Okay. And the percentage of this fibroglandular breast tissue in relation to the fatty tissue, right, is the density of your breast.
Got it.
So the higher the percentage of this fibroglandular dense breast tissue that you have in relation to the fatty tissue, the denser that your breasts are. Okay. And the harder it is for mammogram to kind of see through this dense breast tissue. So that is why it's such an important kind of question that is asked, and it's such an important independent risk factor for the development of breast cancer because it can really obscure findings that we see on mammogram.
Thank you so much for explaining that because I was told, oh, well, we don't really know what we saw, so we're going to do 3D imaging. And I was like, you're the boss. You tell me what to do. So I think a lot of women fall into that category, and we didn't know that.
You're right.
The science, my mom, let's just say she wasn't asked, when she was my age if she had that or not. So I imagine we've come quite a long way.
So common. Over 50 to 60% of the population that we see. Yes.
Oh, okay.
Yes, very common.
Okay. Thank you so much. I just needed to get my question out of the way first. I'm
Done.
sure I'll have
We're
more.
done.
So breast cancer, the second leading cause of cancer death in U.S. women, which is so scary, behind lung cancer, I believe. And about 1 in 8 women will be diagnosed with it. Yet the mortality rate has fallen, right? So that's a great thing. And I would love for you to tell us why that is so we can do more of it.
Yeah. So the mortality rate has fallen over 44%.
Incredible.
Over the last few decades. Staggering, right? Staggering statistics. But what it all comes down to, and the main reason for that, really is early detection. Right?
Okay.
And it's early detection, though, specifically through breast imaging.
Okay.
And the cancer screening tools that we utilize in breast imaging over the last few decades has become significantly more accurate, significantly more precise. And that allows me as a breast radiologist to find and diagnose breast cancers very, very, very earliest stages. Okay. Very early stages.
That makes a lot of sense because I have had 2 very dear friends with pretty aggressive breast cancer, and you'll probably know what this is. I certainly didn't when she said she was on a chemo called the Red Devil. That's what people call them. It was pretty aggressive and pretty rough.
You're right.
But she's one of the lucky ones, and they did catch it early.
Yes.
But that I remember, my mom's friends, a few of them died. It felt like a death sentence.
And
it doesn't
it
have
used
to
to
feel
be
like that anymore.
It used to be. And the single most important tool that we utilize for early detection, for early screening, is screening mammogram. Right? And mammogram helps us find breast cancers. We're talking about tiny, tiny breast cancers, 1 to 2 millimeters in size, right? Tiny, tiny specks of calcifications before a mass has time to develop. And long, long before a patient is ever going to feel a lump clinically.
Okay. So when I was growing up in sex ed class, it was all about the BSE.
Okay.
The breast self-examination.
Yes.
And you do the circles and you do the thing.
Yes.
Do we, I don't know, do we still teach that or just say get in for your mammogram?
We do still teach that.
Okay.
Really, clinical exams should still be performed monthly by patients and yearly by physicians.
Okay.
But, the name of the game really is early detection.
Right.
The early detection, okay?
That
and again,
makes so
mammogram
much
will
sense.
find long before a patient has time to feel a lump.
And I'm curious since this is all about early detection, and by the way, I don't know if I'm just an outlier, but everyone says, oh, it hurts so bad. It doesn't. It doesn't hurt that bad. It's not a big deal. It's a little smushy and it lasts for a minute, and then we all move on and we're happy that we're healthy. We pat each other on the back.
Exactly.
It's not a big deal.
But it's not easy, right?
No.
And I hear women who say, they don't like their breast compression, they don't like getting mammograms. It's uncomfortable. I'm not gonna lie. But listen, I hear you.
Yeah.
I get my mammograms every year as well.
Right.
Okay. Do I want to be having my breasts in compression? I really don't, right? But we're talking about the seconds that women spend
Exactly.
in
That's
compression,
what I was gonna say.
this discomfort, right, will save years and years of our lives.
And that's
years
what it's all
of our
about.
lives.
And you think, if you thought this was uncomfortable, like God forbid it gets worse, and now we're just talking about a palliative care situation. This is the best thing to do. Now, some of us fall into high risk categories and don't know it.
Exactly.
Can you give me some information on how we figure that out?
Of course. So, let's kind of backtrack a little
Please.
bit before we talk about this high risk category.
Yeah.
Let's talk about just the basics.
Okay.
So, every physician that's involved in the care of breast cancer, all of our colleges, we all recommend screening mammograms starting at the age of 40.
40,
For
okay.
women of average risk.
Okay.
And continuing every year, so continuing annually
Okay.
for as long as someone is in good health. And it has been shown that starting at age 40, continuing annually, shows the greatest breast cancer mortality reduction.
Amazing.
Across all studies. It's
Makes
just
sense.
fact. It's fact.
Makes
right?
sense.
And in fact, women who are considered higher than average risk may need mammogram before the age of 40.
Right.
Okay. So in 2021, my American College of Radiology expanded these breast cancer screening guidelines and started to recommend that all women, so age 30, should be undergoing a breast cancer clinical risk assessment.
Oh.
Okay? But then in 2023, they decreased that age to 25. Right? So all young women, all young women at the age of 25 should be asking their clinicians for something called a breast cancer risk assessment. We've been hearing a lot in the media about this risk assessment tool calculator.
Okay.
Specifically, you had the actress Olivia Munn. She had bilateral breast cancers, bilateral mastectomies. She came out and said that this risk assessment calculator saved her life.
Okay.
And what it is, it's a tool, it's a series of questions, personalized questions. And the answers to these questions give you a risk factor, a percent estimated risk for developing breast cancer in your lifetime.
And is this more than just family history?
It is. So the most comprehensive assessment tool out there, what Olivia Munn's referring to, what we offer at UCI Health, is something called the Tyrer-Cuzick IBIS risk assessment. Now, there's many out there.
Don't make me memorize that. I should write that down.
Listen, there's
Say it
many.
again.
It's called the IBIS Tyrer-Cuzick risk assessment calculator. And there's many out there, but this is the most comprehensive.
That's what you use.
It includes things such as personal and family history of breast, but also ovarian cancer. Okay.
How would those be related?
Well, patients who have had ovarian cancer or family history of ovarian cancer, oftentimes that can be linked to breast cancer genetically.
Okay,
Correct.
I didn't know that.
Correct. Especially, like we talked, I'm sure you heard of the breast cancer BRCA BRCA1 and 2 gene.
Yes.
Yes.
And that became sort of more in the mainstream with Angelina Jolie, if I remember correctly.
Exactly. She had the breast cancer BRCA1 gene, and she elected to get the bilateral mastectomies, removal of her ovaries as well. So they can be linked.
And that's more, and excuse my ignorance on the subject, but is that more preventative? That's to
preventative on her side.
And what a choice to make.
It definitely is. Listen,
that's a lot.
It definitely is. But that is more rare in the sense that, not everybody carries that breast cancer gene, but it's also any personal or family history of breast ovarian cancer. It's also your hormonal history, your reproductive history, age of your first child, if you've had children, things like that. So it's a very detailed questionnaire, right? And it's also, history of breast symptoms, breast conditions, right? If you've had history of breast cysts, history of breast biopsies, things like that. And, thank you for mentioning breast density before.
Yeah.
It's the only model right now that takes into account breast density.
Really?
Yeah, we talked about breast density, it's an independent risk factor for the development of breast cancer.
Okay. And I would imagine, because I'm not a doctor, but I'm assuming that it's because it's just harder to detect when you have that.
So it's twofold. So first of all, yes, harder to detect, to see through that dense breast tissue, but just in and of itself, that dense fibroglandular breast tissue is an independent risk factor, which a lot of people don't realize, right?
Oh, yeah. This is the first time I've even heard those words. So, of course, I didn't know. I'm so interested in taking this test. And I imagine, like everything else, well, I took the test, I Googled it, and I found no, we want to go to an actual doctor.
You're right.
Okay.
Because the results of this test should be kind of an entire approach, your entire team's, your clinician, but also your breast radiologist.
Okay.
Because patients who, like we mentioned, average risk is 1 in 8, right? 12.5%, right? And high risk, it's high.
Yeah.
And that's just average risk, right?
Right.
And high risk, you're considered high risk when you're 20% or higher, okay? And so if we get that number, if it spits out a number and it's very, very high, then patients figure out we don't know what to do, right? And so, every patient who comes into UCI Health, we give them that personalized risk score. But not just that, we also give them recommendations.
You don't just send them on their way.
Exactly. Because if you're 20% or higher, then really you should be starting screening mammograms at age 30.
Oh, my goodness.
So 10 years before somebody would of average risk.
And these days, I can't imagine how poor doctors. People are always coming in because they know everything because they Googled it, and they know everything because
Dr. Google.
Yeah, because they spent 5 minutes, typing it in, and now they're also a doctor. So congratulations to us. Do you feel like in your specific line of work, you're having to sort of manage people's expectations when they come in and they kind of think they know everything because they researched it online?
Well, I think that could be said with any specialty.
Absolutely.
But let me tell you, breast imaging in particular, it's such a vulnerable kind of state where, a woman is getting mammograms, your breast is in compression.
Right.
We could potentially be telling them bad news in terms of any biopsies that they need or any diagnoses. So women are already in this kind of heightened state of anxiety.
Yeah.
And so I think, anything that we can do to kind of alleviate that anxiety, counsel them, especially if, they didn't know they were high risk, then they're getting that recommendation, right, for additional imaging. Anything that we can do to alleviate that, but also give guidance going forward.
Yeah, and put the human touch back into the process instead of just doom scrolling in the middle of the night because you can't help yourself.
Exactly.
Now, we're talking about women. Of course, this affects women, at such a high rate, but this does happen to men every now and again, I would imagine.
Absolutely correct. Yes.
And have you personally dealt with men with breast cancer?
Yes, I have diagnosed several in my career. But let me tell you, breast cancer is so rare in male patients, right? We're talking about it accounts for about 1% of all the breast cancers that we diagnose.
Okay.
So unfortunately, women are 100 times more likely to get breast cancer.
Right.
And that's why, routine mammograms are not recommended in men. But
is the same treatment for men?
It would be the same treatment.
Yeah.
Correct. But men, we always encourage our male patients, anytime they have any symptoms, don't ignore them. Any breast symptoms, please don't ignore them. Any lump, any swelling, any discharge, come in for that mammogram because we have absolutely diagnosed cancers in male patients.
Oh my God. I can't imagine how jarring that would be because like you said, women are sort of used to knowing that this bad news is possible, but for a man to say, no, you don't understand. I'm a man, this isn't possible. It's possible.
No, and they shouldn't ignore their symptoms.
Right. And what would a symptom be for a man? Would it be different?
It would be very similar. A lump.
Yeah.
A lump, swelling.
Okay.
Any sort of pain in and around the breast nipple area. And sometimes we also see nipple discharge. So specifically, bloody nipple discharge.
Okay.
So just anything, and I always tell my patients, you know your body the best.
Right.
Okay. Anything out of the realm of what you feel is normal, you have to advocate for yourself.
And it's interesting, just on another personal note, I had a breast reduction a few years ago, and they were, the insurance company, to their credit, was very aggressive on making sure I didn't have any breast cancer issues because, hey, I get it. If you're footing the bill, you don't want to start over again. I understand that. So I feel very fortunate that they were so aggressive about it before the surgery, but that doesn't mean in any way that I'm off the hook now, right?
No,
Things can
definitely
develop.
not. Definitely not.
Okay.
And I don't know if you're of the age. You don't look like
Bless
it.
you.
You don't look like it.
Thank you.
But certainly, even patients who have had, prior augmentations, prior, reductions should absolutely be considering screening mammogram.
Well, in that conversation, I am actually, that makes me curious about people with implants. It's, very common. People have them all the time and they're so real looking these days. You cannot tell the difference. Is it harder to diagnose breast cancer in somebody with implants?
I'll tell you, it's kind of a couple layers here, right? So patients are always worried about breast implants when they come in terms of the mammogram, right? First of all, is us being able to see the breast tissue, but also how does that mammogram affect the actual implant
it's going
itself?
to make it lopsided.
Exactly. So our technologists are well trained, well versed in doing mammograms in all patients, especially breast implant patients.
Okay.
And they have a technique where they manually kind of protect the implant, bring that implant back, push that implant back manually with their hands so that we are able to visualize that breast tissue better.
So there's actually a different system.
There is a different system. There's a different technique that is utilized. And it's actually more images that we take in patients with implants because we know that that implant can hide that breast tissue.
That is so good to know. I just figured it would just be harder and that's just part of the risk. But no, they know what they're doing.
They do.
And, I know we kind of talked about this, but there are women out there, if I have to drag a friend there and do it, just rip her shirt off and shove her in the mammogram. Hey, I'm a good friend. But what would you tell somebody who's just like, I don't know, I just don't want to do it. I've heard that it's uncomfortable. I've just heard too many horror stories.
Yeah. Exactly like we talked about.
Yeah.
I hear you. Okay. I definitely hear all women out there.
I've done
I
them.
hear you.
Yeah.
I get them every year as well.
Right.
It's not comfortable. It's not, okay? But like I said, the couple seconds of discomfort saves years and years of our lives. And to me, that's worth it.
That's a great trade-off.
Mammogram saves lives.
And that
really
is,
do.
That is the takeaway. Dr. Tsai, thank you so much for your time.
Oh, no, thank you for having me.
This is literally going to save people's lives, and we are so grateful to you for talking to us and having this great conversation.
Thank you for having me.